Hello and welcome. I'm Bob Cusack, Editor-in-Chief of The Hill. Thank you for joining us for our program, Antibiotic Resistance, a Looming Public Health Crisis. Before we begin, I'd like to thank our sponsor, the Pew Charitable Trusts, for supporting today's conversations. Whether through overuse of antibiotics, inadequate infection prevention, or natural evolution, bacteria can become impervious to the very drugs meant to kill them. These antibiotic-resistant pathogens, including those that cause some form of pneumonia, tuberculosis, and other illnesses, can result in millions of infections and thousands of deaths per year in the United States. Globally, these resistant infections killed more than 1 million people in 2019, more than HIV or malaria. Some estimates predict that without significant changes, antibiotic-resistant bacteria will kill more than cancer by the year 2050. What threats do antibiotic-resistant superbugs pose for the future, and how has COVID-19 informed our approach for pandemic preparedness? What is being done to develop new antibiotics and bring life-saving drugs to market? And how can policymakers stimulate innovative drug developments to keep pace with evolving diseases? We're going to put these questions and more in front of our fantastic speakers. But first, a few housekeeping notes. You can tweet us at The Hill Events using the hashtag TheHillHealth. We are broadcasting live and will be taking your questions throughout the program. As with any live stream, you could experience occasional trouble with the video. Refreshing the page should, in most cases, fix the problem. My first guest is Senator Michael Bennet from Colorado. He's a member of the Finance and Agriculture Committees and has made antibiotic resistance a legislative priority with his sponsorship of the Pasteur Act, which I'm looking forward to discussing more. Welcome, Senator Bennet.
Thanks, Bob, for having me, and thank you for addressing a topic that I think deserves far more attention than it's been getting, so I deeply appreciate that.
Well, Senator, how did you get involved in this? We have a lot of speakers today have personal stories. Did you hear from constituents? What made you realize, wow, this is something that's not getting enough attention?
As you said, I started to read scientists that were saying that the leading cause of death by 2050 for the world was likely to be antimicrobial resistant infections, and I didn't know what that was, and I didn't, but it caught my attention. For sure. And then I realized that we have a complete market failure in the United States and globally. And as a result, humanity is not developing these important drugs. So I wrote the Pasteur Act and introduced it with Senator Todd Young on this side and Congressman Ferguson, who you're going to have later, as a way of addressing that, fixing the market failure and making sure that we are anticipating what's coming. Unlike COVID, where, it came and we weren't prepared, I'm hoping, not just hoping, we need to be prepared for the next event.
You've said antimicrobial resistance is a looming public health and national security crisis that may one day be our next pandemic if left unaddressed. How has the pandemic changed our thinking along for this issue? What have we learned?
I think it's really changed a lot. What we've learned mostly is that we can't be unprepared. We have to be ready. And in the case of COVID, we were ready in a sense because we had decades of work by pharmaceutical companies on technologies that became the vaccines that we were able to lead the world in. We got to a result very quickly, which is in historical terms, which is a reason why, we know we have to invest on the front end. But I think we were unprepared in other ways. Our public health system was unprepared. We saw the great inequities that exist in our healthcare system. We were unable to protect ourselves or our frontline workers because we didn't produce masks and protective equipment in the United States. This is an opportunity for us to lead the world. And I think one of the reasons why it hasn't caught people's attention in the way that it might is that antibiotics are actually quite effective. We've come to rely on antibiotics as a solution to infection. What we have difficulty imagining is what a world looks like when you have an infection and there is no antibiotic and it's widespread. The economic result of that could be catastrophic for the world, and obviously the impact in terms of human life could be enormous. So I think that an investment of this $11 billion to create effectively a subscription model. So smaller drug companies in particular can know that they're going to be able to stay in business while they work on something that may not be that important to us today, but is going to be very important to us tomorrow, that they're able to survive in a newly formed market.
Senator, as far as the mood on Capitol Hill, we've seen my colleague Reed Wilson wrote a book on Ebola years ago and said it's so important back then to invest millions now so you don't have to spend billions, or with COVID, we've seen trillions now. Do you think that has changed on Capitol Hill, kind of the approach from others who said, well, maybe we shouldn't be spending this much money, that they view it more as an investment that can prevent tomorrow's disaster?
I really do. I really do think that's a change in the way people think about things. COVID was a big reason why, and also I would say that after decades of a fiscal policy that really involved cutting taxes for the wealthiest people in the country and fighting 2 wars that lasted 20 years in the Middle East, I think the American people are demanding, as they should, that the Congress invest in them and invest in our public health infrastructure as well as our actual infrastructure. So I do think that's a sea change. One other point I would make is that, these pathogens are not, we can't fix this problem by ourselves. This is a global catastrophe waiting to happen, but it's a global opportunity for us to lead, I think, in terms of innovation and the coalition around the world that's going to be necessary to make sure that everybody on the planet is benefiting from these new antibiotics. And I know from having spent a lot of time working on this issue that others around the world are looking at the Pasteur Act to plant the flag for them that we're going to take this seriously, and so should they.
On the Pasteur Act, you mentioned you have Senator Young, so it's a bipartisan bill in the Senate. It's a bipartisan bill in the House. Last I checked, it was 20 Republicans and 20 Democrats on board. What are the prospects in this election year? Very difficult to move legislation. Do you think that this could get to the White House?
I was laughing when you were talking about the mood in Congress. But I guess what I would say is we're going to look for every opportunity to pass this. We're going to look for every avenue to pass this. And what you said earlier and what we talked about earlier, I think has been a game changer, which is people realize on the back end of hopefully on the back end of COVID, that we've got to be better prepared the next time. And that's why I think we're going to be able to get this bill passed. And I'm glad it has bipartisan support in both houses. Unfortunately, I can't address the general dysfunction of Congress, but I do think this is one of the bills whose time has really come, and the time is now, and I think we'll find a way to get it passed.
Have you talked to the Biden administration as far as where they are on it, and would obviously be helpful if they came out?
I have. They're supportive, and they've indicated that with line items in their budget, but they can't do this by themselves. They need Congress to pass the legislation.
As far as this issue with the healthcare community and medical providers, what do you think is the most important for them? This is a scary issue, but you don't want to spread fear. What do you think the role of stakeholders at the federal and state level?
It's such an important question. You, at the very beginning of this conversation, you read out or spoke about a litany of things that create antimicrobial resistant diseases. And one of those things is antibiotics not being used properly, not being administered properly, and being abused. That is something that has to change. And our bill says that, we have to make sure that they're prescribed properly. And that would be an important part to diminishing the risk of antimicrobial resistant diseases going forward. The other thing that I just would call to your attention is that I think if we are going to invest $11 billion, we need to do it for real innovation, not just to do follow-on drugs that don't really establish a new threshold for antibiotics. And we call for that as well in the bill. And I think that will be important in the hands of medical professionals who are going to be developing these drugs and making these judgments.
As you mentioned, we're in a global economy. The pandemic originated in China, and then before you knew it, it would spread so quickly to the rest of the world. Internationally, what is the situation? Are there other countries that have done a good job, or maybe even other states that are doing something that we should model something after, so that people get the care they need?
I think actually the Pasteur Act has set the standard. We haven't passed it yet here, but I've talked both to people in the UK that have led very seriously in terms of ringing the alarm that we need to do something. We've had conversations with the G7 as well. But they're all looking to us for leadership, and that's reasonable. I mean, we are the most powerful and most dynamic economy in the world, and we've got an amazing healthcare sector that is developing new therapies all the time, and they really need us to lead. And there is not really an example, except I would say of public policy urgency, where people in the UK and throughout Europe have really begun raising the alarms.
As far as additional co-sponsors, are you and Senator Young working the Senate floor to get people signed up?
We're working on it, yeah, we are.
And do you think that, obviously it's tough to pass individual legislation, but as you know, Senator, there's always kind of vehicles that are moving, whether that's fund the government. Do you hope that maybe to attach this legislation to something moving?
I think we'd like to find some vehicle as the Help Committee does its reauthorizations, or other opportunities arise for us to deal with long-term healthcare questions. This would be a very appropriate bill to pass as part of that. I think it is, as you said, very unlikely that it would pass by itself, but that also is not impossible. We're going to look for every avenue to get it done. Around here, you just never know. You never know until it happens, and that's why you just have to stay after it. I'm very grateful to have the partnership of Senator Todd Young. He's well respected on both sides of the aisle, and I think that'll help us get it done too.
Well, we'll be watching that legislation very closely. Thanks again to Senator Bennet.
Thanks again. Thanks so much for having me.
It's now time for the sponsor perspective of our program. I'd like to introduce Dr. David Huynh, a director of the Antibiotic Resistant Project at the Pew Charitable Trusts. He's joined in conversation by Jason Jedlinski, publisher and general manager of The Hill.
Dr. David Huynh, thank you so much for joining us today. Wanted to ask you, can you help us understand the threat of antibiotic resistance? What are the real-world implications for the average person?
Sure. The inability to treat bacterial infections because these bacteria develop resistance to antibiotics we have available on hand really poses a threat to every aspect of modern medicine. CDC already estimates that about 35,000 people die each year in the United States from antibiotic-resistant infections. And another recent study has shown that about 1.3 million people a year worldwide are dying from resistant infections. And that number is higher than HIV or malaria globally. So it's already happening. And the concern here is that if the issue of antibiotic resistance goes unchecked, we may be seeing a future where some of the most simple and common infections is no longer treatable, or there may be a significant difficulties treating it, and that carries enormous implications for the entire how we deliver healthcare. Bacterial infections happen as a complications for many of the therapies and procedures that our healthcare system provides, including chemotherapy or elective surgeries such as hip replacement. And if we don't have effective antibiotics on hand, if these antibiotics are no longer able to treat these infections, then we are really undermining all the successes and advances that we have seen across the healthcare setting.
Well, it makes sense in that context why it's described as a public health threat then.
Absolutely. It is a public health emergency that needs to be addressed. And it's very much all interconnected with not just every aspect of healthcare, but a lot of the different aspects of public health as we are learning from the COVID-19 experience.
Yeah, the last 2 years have been characterized by this global pandemic. Tell us what impact that's had on antibiotic resistance.
We have seen significant increases in the amount of antibiotic-resistant infections among patients who have been hospitalized during the pandemic. The CDC published a report last fall that showed in 2020 those numbers have gone up for some of these really resistant infections, including MRSA, which is the most well-known of all the different so-called superbugs. And this really illustrates the point of why having effective antibiotics is so important when it comes to pandemic preparedness. In the case of COVID-19, most of these patients are in the hospital for long periods of time. They're typically ventilated or on a ventilator for long periods of time. And there's a lot of medical devices and instrumentation being used, and all of that puts the patient at risk for developing bacterial infections. So it's really important for us to be able to treat those infections when they happen, and that's where having effective antibiotics is so crucial, and why it really illustrates the point of that having these antibiotics available and effective to us is part of a comprehensive and complete pandemic preparedness plan.
You mentioned effective antibiotics. I think some viewers may wonder, if this is so serious and such an emergency, why not just develop new antibiotics? Why not replace what's becoming less effective with new treatments?
No, that's a great question, and it's a very complex answer, as you're going to be hearing during this event, the different aspects of this issue. But the bottom line is developing new antibiotics and making them available to patients for treatment is a very resource-intensive and a time-consuming process. An average antibiotic takes about 10 to 15 years from the time of discovery all the way through its approval and coming onto the market. And it takes about $1.3 billion on average for each antibiotic. The problem is that the return on investment, once those antibiotics hit those markets, is just not there, and most of the time cannot recoup the amount of investments that we just talked about. So, for example, we have seen in the last decade several antibiotic pharmaceutical companies go under, even after successfully getting a new antibiotic approved by FDA, because of these challenges where we have essentially a broken market system that makes it difficult for new antibiotics to be sustained and made accessible for patients.
Yeah, it sounds like the incentive simply isn't there to address this emergency. Can you tell us, what is Pew Charitable Trust doing about this issue?
Well, the Pew Charitable Trust, we're attacking this from two fronts. The first is around antibiotic stewardship. We're advocating for policies and research to really try to find ways to spur the adoption of antibiotic stewardship activities across all healthcare settings. And when we say antibiotic stewardship activities, these are policies and actions and interventions that can be taken to really minimize and reduce the amount of inappropriate or unnecessary antibiotics that are being given, while at the same time making sure those patients who truly need an antibiotic gets the optimal regimen as possible. So that's one area that we're focusing on. The second area is essentially the second half of the same coin, is why we're buying time with being judicious with our antibiotic use to make sure we preserve the effectiveness of the antibiotics that we have on hand. We also need to really reinvigorate the antibiotic pipeline. The pipeline has really dried up. And it's still not where it needs to be in terms of trying to keep pace with the speed and spread of the emergence of these antibiotic-resistant bacteria. And this is where we really need to zero in on how do we provide economic incentive policies to spur the development of these of new antibiotics. And this is where the Pasteur Act comes in. The Pasteur Act it addresses both fronts. It really it helps with antibiotic stewardship programs by dedicating resources for hospitals, especially those in the resource-limited settings. But more importantly, it addresses the broken market issue by delinking the value of antibiotic as a medication, not delinking that away from the volume of sales, and actually assigning a public health value to it and creating a more predictable and sustainable revenue for those researchers and pharmaceutical companies that have invested in the development of those new antibiotics.
We've all heard as patients that we should not be seeking penicillins for a common cold, et cetera. What else can viewers of this event, this program today, do to help advance action on this?
Well, I think you hit it right. That's exactly it, what you said, in terms of trying to make sure that when you as a patient go see your doctor, have an open conversation if an antibiotic use is being discussed as a potential option. It's very important for you as a patient to have an informed understanding and be part of the decision-making process, because we know from a series of studies that have shown that the patient expectations and the patient sometimes pressure plays a significant role in your providers and your physicians decision-making process when it comes to antibiotics. So we really encourage patients to have that open conversation and have a good understanding of what the pros and cons are, because antibiotics do have side effects associated with it that the patients and sometimes even doctors may not fully appreciate the extent of it. And that's why it's really good to know going in that some of these conditions, such as viral infections, including COVID or bronchitis, and many of these infections do not need an antibiotic. The antibiotics don't help. So we strongly encourage to have those discussions out in the open during your doctor's visit.
Yeah. Lean on the physician's expertise. Always good advice. Well, Dr. David Yun, Director of the Antibiotic Resistance Project for the Pew Charitable Trusts, thank you so much for joining us. We appreciate your support of today's program.
Thank you for having me.
Thanks again to David Yun and to the Pew Charitable Trust for supporting today's important conversations. Combating antibiotic resistance requires a cross-sectional response from medical and research communities. Joining me now to discuss the landscape of antibiotic innovation are Dr. Lillian Abo, Professor of Infectious Diseases at the University of Miami, Dr. Christopher Burns, Founder, President, and CEO of Bennet Pharmaceuticals, and Kevin Outerson, Executive Director of Carb-X, a global nonprofit partnership accelerating antibacterial products to address drug-resistance bacteria. Thank you all for joining me. I want to start with Lillian. You're a big proponent. This is an issue. I was talking to Senator Bennet. It's a scary one because it obviously deals with death, but you lean into education. And what do you think is important to educating both the public and the providers who are watching this right now?
Hi, good afternoon. I think this is a very important topic, very near and dear to my heart, not just because of education, but as a clinician in the front lines and as an administrator in healthcare. Education has to start early in life, as early as childhood in schools, where we educate kids that smoking has, consequences. We need to start educating about antibiotics. Early in life is when we learn the most. Then as we grow up, high school and medical school or college, we really need to continue that level of education. And then we need to reform our medical school curriculum also to educate healthcare providers, nurses, anyone entering the workforce, how to appropriately prescribe antibiotic and the consequences of inappropriate use of antibiotics. So education has to be at all levels. And then through society, public campaigns, programs like this are important. And I am a big supporter of the Pasteur Act because that will also provide through Congress and through Health and Human Services, a pathway to allocate funds and resources for education and antimicrobial stewardship programs.
Kevin, HHS recently announced a $300 million grant to Carb-X. Can you describe that and what you'll be doing as part of that project? Oh, I think we can't hear you. It's the way of the world.
I was saying that
we
also have $70 million in the Wellcome Trust that was announced on the same day. But Carb-X exists because the small companies in this space are not getting the private investment they need. And so we're non-dilutive, we make grants. We also support the companies with technology and experts so that in 5 or 10 years from now, we're not sitting around wondering why we don't have any antibiotics on the shelf that are available and useful.
And how long has this been in the works?
Carb-X was founded in 2016 with the largest public-private partnership in the world supporting antibacterial innovation. And to date, we've funded companies in 12 countries, 92 projects total, about $365 million spent as of today. So we're really grateful for our funders coming back and renewing our ability to support projects going forward.
Christopher Burns, where are we big picture on this? And what do you see that policymakers should be doing more? Where are we on funding? Where are we on legislation? Lillian mentioned the Pasteur Act. Where do you think we are kind of from a big picture, 30,000 feet?
So to give the background, you know, when we started 12 years ago, we were just 3 people, and we were trying to invent new drugs. So we were at the beginning of the story. Now, 12 years later, some of the things we've invented have made it all the way through the clinical trials and are ready to be filed for approval and commercialization. So I think each party looks at this from a different angle. Clearly, we've been very successful at putting what they call push incentives in place, like Kevin's Carb-X, which we've been beneficiaries of, where you innovate, you invent something new, you start to bring it to the later and later stages of development, and then pre-commercial. I think what we're all conceding is that there's a bit of a cliff, and each new innovation reaches the edge of the cliff and looks across the chasm and is trying to figure out how to get to sustainability, because sustainability at the end of the day is the key to all of this. And so I think where we're still struggling is from the cliff beyond, if you want. You know, you get new innovations, you bring them through the clinic, and then all those push incentive dollars start to dry up, and you find yourself alone trying to bridge to commercial sustainability, profitability. I mean, without that, you're not going to get investor dollars. And so I think what Pasteur is trying to do is say, look, if you can get this far, we will help bridge you across the chasm, and we will help get you to sustainability by helping you, you know, until you can fly on your own, basically. Mm-hmm. And there's really only a couple of other pools of capital right now that can do that. One is within Barda, which is a procurement angle through BioShield. And the other is a new pool of capital that has been formed by the pharma companies called the AMR Action Fund. And those would have the opportunity to participate in the later part of the cycle, maybe more than the early part.
Lillian, you're a regional and national expert on COVID-19. What have we learned on the ground on other policy issues? You know, we have so much going on. We've got a pandemic. We're talking about antibiotic resistance, but we're also, you know, mental health is a big challenge now. Opioids is a big challenge now. What have we learned over the last 2+ years?
Wow, we have learned a lot. And as you very well know, there has been a lot of mistrust, right? Both in politics and in healthcare. So we really need to start rebuilding our society and rebuilding that trust. Our healthcare expenditures have dramatically increased. We're spending about 19% of our GDP in healthcare. And healthcare in America, the quality of life is not necessarily the best in the world. We're spending over $4.5 billion every year in managing 6 of the most resistant bugs. So as we hear, we really need to take the lessons from this pandemic. Where are we spending our dollars, and what's the value that we're bringing to our society to improve the longevity and the quality of care? I think it's really important to also understand that spending dollars on prevention is extremely important. And that's part of it, is breaking the infection control, the chain of transmission of superbugs, using these innovations and technology also to focus on prevention, really preventing the resistance and targeting these drugs that we really need to give the best value to patients. And also very important, we've learned in the last 2 years, the social determinants of health, right? We have a big opioid crisis, a big mental health crisis. All of this intersects. If we don't treat these underlying conditions, if we don't look at our rural areas, if we don't look at the access to care in our counties, in what do we do in our safety net hospitals, we're really not going to solve this crisis. We really are seeing this problem across all races, religions, economic status. So it's really focusing that every part of society is important and we all need to work on this together. It's doable, but we really need to focus on value, not just throwing dollars. It's really how are we allocating those funds to improve the quality of care.
Kevin, you recently said antibiotics are unlike other medicines. As bacteria evolve to become resistant, the problem keeps getting worse. We have to run faster just to avoid falling behind. What pace are we running at today, and is the bacteria faster?
Whether it's bacteria or coronavirus, they just adapt, they evolve. And so every time that we do something with a clever intervention, we have to be thinking about the future. If somebody invented a wonderful cancer drug, that cancer drug should work forever. But the best antibiotic we'll have ever seen, as soon as it's introduced, we need to be inventing its replacement. And so that's one of the reasons why things are so hard in this space. It requires us to be keeping ahead of the longest foe of humanity. I mean, think of the Black Plague. Bacteria have really had their way with humanity. And it's only in the past couple generations that we've had these amazing drugs that enable our modern civilization to be possible. Good luck doing cancer treatment or knee surgery or cesarean sections. All those things would be more dangerous without antibiotics. And so it's really worth protecting.
Just a quick follow-up on that, Kevin. As you said, you work with other countries. What have you learned from them? Anything surprising of what other countries are doing, and how do we stack up?
Well, the ideas behind the Pasteur Act have been talked around in various countries for a number of years. I'm a strong supporter of the Pasteur Act, but England, the United Kingdom, kind of got ahead of the game and actually has implemented this subscription idea behind the Pasteur Act and announced the first 2 drugs in their program last year, or now implementing it today. That's great news, but the English economy is fairly small compared to the rest of the world, and it's not enough by itself to do anything useful for antibiotic innovation. It works as an example, and it works if other countries like the U.S., comes and follows suit. So I'm hopeful that countries that represent the largest markets of the world can work together and actually get this done, because that's how we'll make companies like the one that Chris Burns leads and many others not go off the cliff into oblivion. It's tragedy when great science works for a decade and then gets crushed because of bad economics that really we can do something about with Pasteur.
Chris, you've gone through, you mentioned clinical trials, and you've gone through the kind of the government process. What makes you the most apprehensive about the way we approach drug development, and is there a way for the process to be streamlined?
I think on the development front, I think the FDA in the last 5 years has been incredibly flexible and incredibly helpful to understand that we're in a capital constrained environment, that what is sufficient on the risk benefit scenario is X instead of X times 3. And so I think that's been very helpful. We always look forward to the FDA being a partner with us in that front, and I think they've shown that they're willing to do that. People like me, we spend all of our days trying to find the capital to advance, to show what the drugs can do, and so we tend to gravitate always back to the capital rather than the development, the science, even though we're all scientists by training. But I do think it's it's a partnership between the policymakers in terms of funding, the development funding, to be honest, what happens after development is finished, and then the FDA maintaining itself as a productive partner in the equation.
Lillian, we have a question for you from one of our viewers. This is from Karen Sassa, owner of something called Focus, Phocus. And she asked about education. How are we educating prescribers on stewardship, on prescribing appropriate therapy? How can pharmacists play a role in making sure physicians are prescribing the right way and appropriately?
Wonderful question. And I am a big proponent of pharmacists. Pharmacists are our right and left hand in clinical care. I think everyone plays a role, again, from medical education, pharmacy schools, all the way to the front lines, right? Anyone in any pharmacy, whether you're in an outpatient pharmacy or working at a hospital, has a role. We really need to focus on antimicrobial stewardship programs. The ID Society of America and the Society of Healthcare Epidemiology of America have wonderful guidelines. And part of those guidelines, we have really carved out what are the components. We have curriculum for education of residents, students, and we have curriculum for infectious disease providers in training, also in antimicrobial stewardship. So that's part of the education, really teaching people how to prescribe. Using the example of cancer, you cannot prescribe chemotherapy unless you are an oncologist. Nobody will give you a chemotherapy drug without the expertise. Anyone can prescribe an antibiotic. So really, pharmacists have a very important role at the front lines educating, but we as doctors, we also need to do our part and hold ourselves accountable. So that's the role of stewardship. It's really using these valuable drugs in the best way. I always use the example of we don't do anything with new drugs if we don't know how to take care of them. It's like giving your alcoholic patient a different kind of brandy, a more refined, alcohol. You really need to teach people how to drink, not just serve them a different drink.
Kevin, as far as the urgency here, on a variety of issues that, especially in Washington, everyone talks about the urgency of climate change and other issues that we must act now. How important is it to act now on this and perhaps pass the Pasteur Act as quickly as possible in a bipartisan way?
Well, it was mentioned earlier in this broadcast, 1.27 million people dying now of drug-resistant bacteria. It's killing people mainly, around the world, not necessarily in the United States. Tens of thousands in the U.S., but over 1 million worldwide, killing more people than HIV and malaria. Why isn't that getting our top-tier attention? But also, what's happening is that every day we see and we hear the stories of small teams, science teams, research companies, some of which have been together for a decade, having to break up, going off into other fields. The intellectual capacity of the world to create new antibiotics is being diminished every day. It's a crisis for these little companies. And eventually that becomes a crisis for all of us. If we'd lost the last person who knew how to do calculus, we're losing people who know how to make an essential part of civilization that must be renewed every generation, or else we'll slip back into the pre-antibiotic era. So, it's urgent on so many levels. People dying, teams dying, and the future need to keep us all safe.
We have run out of time for this segment. I want to thank our panelists, Dr. Lillian Abo, Professor Infectious Diseases at the University of Miami, Dr. Christopher Burns, founder and president and CEO of Venetrix Pharmaceuticals, and Kevin Outterson, Executive Director of Carb-X. Thank you so much. Great discussion.
Thank you.
Thank you.
I recently spoke with Congressman Drew Ferguson from Georgia about his work championing legislation to combat antibiotic resistance. Take a listen to our conversation. Congressman Ferguson, thanks for joining us today.
Glad to be with you.
This issue of antibiotic resistance, you've introduced legislation with Congressman Doyle, a Democrat from Pennsylvania, called the Pasteur Act that would tackle this problem. This is a bipartisan bill. Can you describe it and its chances of passage this year?
Yeah, so we recognize that not only here in the U.S., but globally, we have a real problem with bacteria that are resistant to the antibiotics that have been produced. And I think we need to recognize that we have the economics of antibiotic research and development and production are not working not only here in the US, but around the world. And there's some very dangerous bugs out there that are creating significant amount of fatality around the globe. So what we've done is we've identified where a major problem in the development and the distribution of these drugs exist. And that is from the time that the drugs are researched and developed, when they have to go through this long phase of approval with the FDA, and then they have to find a market. And what happens all too often is that we push drugs to the development phase, but then we got to pull these drugs into the marketplace. And what the Pasteur Act does is that it pulls the drugs into the marketplace, and it makes sure, and basically what it does is it ensures that the drug maker and manufacturer of this is not going to go bankrupt while they're waiting for these drugs to come to market.
And this legislation, I mean, it's sponsored. I was looking at this morning, 40 in the House, 40 co-sponsors, 20 Democrats, 20 Republicans. Ted Lieu, who's on the left, Mark Wayne Mullen on the right. This has been referred to a number of committees, including the Ways and Means Committee, Energy and Commerce. You sit on the Ways and Means Committee. When it's sent to so many committees, because this is such a vast piece of legislation, that can complicate things. Are you confident that it can move? There's a Senate companion as well. I mean, there's some momentum here, but is there enough momentum to actually get it done?
Well, we know how important the problem is, and the fact that you've got this many co-sponsors on both sides of the aisle shows that this is a bipartisan and a bicameral issue. So the reason that it touches so many committees is that one of the benefits of this plan, this subscription type service that this legislation would create, is that in return, the federal government would also get access to these drugs at virtually no or very reduced cost. And so that means everybody from Medicare to Indian Health Services to the VA to DOD, all of these different agencies that provide some level of health care for groups of Americans would have access to these antibiotics that have been produced. And so that's one of the reasons for that it seems complicated. However, there's a real benefit to each of these entities. And we think that it's going to be a positive that we've got so many folks that are engaging from such a broad cross-section of both conferences.
Now, Congressman, you said antimicrobial resistance is a looming public health and national security crisis that may one day be our next pandemic if left unaddressed. So how has the pandemic changed our thinking and policymakers' thinking around future preparedness? And will public health preparedness become more of a priority now that we've had the pandemic?
So, look, we've learned a lot of lessons during the COVID-19 pandemic. One of the things that we've seen, and one of the great success stories out of this, is that because we had been doing research in the area of viruses for so long, and we were looking and all of the work that had been done with the MRA technology, we had stuff in the pipeline and we had technology that we could adapt to produce a vaccine. One of the problems that we have with bacteria right now is that we don't have that same pipeline of products and research that have been moving forward. We take for granted all too often the fact that the antibiotics that we have that have been so successful, they almost appear as miracle drugs in so many cases, and we take that for granted. But the bacteria around the world are really evolving, and they're evolving at a very quick rate for a lot of different reasons. And so what we've got to do is we have to have this pipeline of technology ready to go. We got to have products ready to go. We're going to pay for this now, or we're going to pay for it later. And it's always cheaper to do it on the front end and be in a preventive mode than it is in a reactionary mode in the middle of a disaster. So, one of the things that we've learned about pandemics is to be prepared and to be thoughtful. And there are a lot of different components to it, but this is a really important component to it.
As far as the cost, and you mentioned that, and cost is always a big concern in Washington, but the cost of developing antibiotics is significant, and sometimes the payoff is not significant. As you say, many Americans, we take for granted the treatments that are out there, the antibiotics are out there. How can policymakers incentivize for production so it gets to people who need it?
Well, look, we've got the research and development component here. So what we lack is funding for these drugs to get them across the finish line into the marketplace. And keep in mind, a lot of the drugs that are made are long-term care drugs, things dealing, for example, with diabetes. If you're diabetic, then all too often you got to take insulin for the rest of your life. Cancer treatments tend to be longer types of like longer types of treatments. However, if you have an effective antibiotic, usually that's a short-term treatment, and then the patient doesn't need it again, hopefully ever. And so the volume that a manufacturer needs to sell to make up for the research and development costs and bringing the drug to market, they look at it and go, well, the return on the investment isn't that great. What we're trying to do is to incentivize that development and getting it to the marketplace with the Pasteur Act. So again, think of it as we push the drug through the development phase. Now we're pulling it into the marketplace, and we potentially can save billions, if not trillions of dollars on the back end. And most importantly, we can save tens of thousands of lives every single year. I think there are over 40,000 deaths in the US alone due to these resistant bacteria, and that we just simply don't have antibiotics to fight them. I saw this very early on in my dental practice. I was a practicing dentist for more than 25 years, and this is something that we fought constantly, the evolution of bacteria that basically made it more and more difficult to treat very serious infections. And this is something that's going to continue to be an issue going forward.
So is that what got you into this issue? You mentioned your background in dentistry. Is that something that this is where you started to hear people / constituents saying this is a real problem?
Well, look, it's certainly, based on my background, I was very aware of it. And I've also experienced it firsthand in the clinical setting. But also looking at the overall development of these products from a pandemic standpoint also got my attention. And here's the other thing that I think that another driver in the interest here is that we've seen what's happened before is these smaller companies develop these unique antibiotics and they go bankrupt waiting to get the product to market. And what happens is sometimes our adversaries will come in and buy that intellectual property or buy that company for pennies on the dollar. And when that happens, then guess what? China gets the technology, they get to produce the antibiotics. And once again, we are at the mercy of one of our adversaries in getting the resources that we need. So this becomes a national security issue as well, that we want to make the things that Americans need right here.
Just last question. As far as it getting over the finish line, what's the role of stakeholders? Can they push for more? And if it doesn't pass this year and the House flips, would this be a priority for you in the new Republican-led House?
Yes, it's going to be a priority going forward, but let's get it done now. The sooner we get this done, the better chance we're going to have at getting better results sooner. We don't know when the next pandemic is coming, but we know that there will be a pandemic. And so if you go back and look over over hundreds and hundreds of years, we know that this is going to happen. So let's get it done now. So for stakeholders, again, talking about the importance of doing this, looking at the Pasteur Act as a good, solid, viable solution, and talking about the benefits of this. If stakeholders will do that with members of Congress, and I think we've got a real shot at getting this across the finish line this year. And that should be our goal, is to get it sooner rather than later.
Yeah, certainly an important issue that doesn't get as much attention as it deserves. Congressman Ferguson, thanks for joining us today.
Thank you. Glad to be with you.
Thanks again to Congressman Drew Ferguson. I'm now joined by former NFL player Brandon Noble, who is a superbug survivor. He says his MRSA infection is responsible for ending his NFL career, and he has been an ambassador for spreading the word about antibiotic-resistant infections. Brandon, thanks for joining me. Oh, I think you're on mute.
I got hit in the head a lot, so sometimes I forget to undo the mute button there. Sorry about that.
All of us. But thanks for joining us. I know this is a personal story to you. I know you've written about it. Can you tell our viewers your experience?
Yeah. So back in the early 2000s, I was blessed with a MRSA experience. I was playing for the Washington Redskins. I guess the Commanders now. And I had signed as a free agent there. And in 2003, I actually tore my ACL, my MCL, my PCL, and dislocated my kneecap in my left knee. And I'm telling you that for a little bit of perspective on this whole thing, right? So that's technically a career-ending injury. I came back the next year and was able to play football for the Skins. And from after the 2004 season, my right knee had a little cartilage floating around in it. And I was at the point in my life in my career where it was like, hey, we should probably go take care of that right now. So I went back to my orthopedic, and he cleaned me out, just a nice easy flush, and got all the debris out, and just a scope, right? I expected, especially after blowing my left knee out, being up and moving in a couple of days wouldn't be an issue. Get back to training for camp. And they took my stitches out about 7 days after the operation. And I was at Redskin Park. And sorry, I don't know what they call it now. They're the Redskins to me, so I'm just going to keep saying that. And they took the stitches out, and I woke up the next morning about 24 hours later, and I had this little tiny hot spot, like it was like the size of a quarter on my knee, right where the porthole was, and it just felt like somebody was lighting me on fire right there. And so I went into the facility and told the training staff. The training staff sent me to the team orthopedic, who unfortunately I had not gotten along with really well over the course of my time there. I didn't let him do my reconstruction of my left knee. And so he had some kind of unkind words for me. And he told me, he looked at it. He goes, well, you probably got an infection. Why don't you go back to your doctor in Charlotte and have him take care of that? And so this was like a Thursday night. I called my agent. I was like, I don't know what to do here. All right, take it easy. They do a little test, and within 24 hours, I am on the sofa, unconscious, laying there with a leg the size of a tree trunk, that looks like it's on fire. And basically, my mother-in-law, who's a nurse, was coming into town for my daughter's second birthday party, which was happening on Saturday. And she looked at my leg, and she looked at my wife, Mary Kate, and said, Mary, you got to get him to the hospital right now. My agent called the orthopedic surgeon for the Washington Capitals, who he knew. They sent me down to Sibley Medical, and I learned about MRSA for the first time. I was laying in that hospital bed after they kind of calmed got the pain to a manageable level. And the infectious disease doctor came in and said, sir, you've got MRSA, and honestly, if you'd waited another 12 to 24 hours, we'd probably be cutting your leg off, or something worse would be happening. And so there I was, right? I'd never heard of it, had no idea what it was. I'm laying there having somebody tell me that they might be cutting my leg off, or I might die. It was at the time, again, I was heavily sedated, but as I look back on it, that's a very scary moment to get to in about 24 hours.
And then you find out that you're not alone. You learned about MRSA you didn't know about before, and a lot of people don't until they get it and then they educate themselves. Was it a difficult time also just mentally with your family and your colleagues in the NFL? And they probably didn't understand it fully either.
Yeah, look, at that point, this was, I guess, so this was like 2004, 2005. Like nobody, again, like you said, like not a lot of people talk about it right now, and definitely weren't talking about it back then. And I was one of the first guys in the NFL to get it. And that year, there was kind of this little outbreak in the league where there was a pocket of guys in New York. There was a pocket of guys, I think, in Cleveland and in Tampa. And we had a handful of guys in Washington get it that year. And it was really kind of one of these things that all of a sudden the NFL became very aware of and started handling things differently in the locker room, the training room, just kind of how we look, football players are disgusting, and kind of better hygiene as a unit, as a group. But yeah, look, I had two little kids. I had like I said, it was my daughter's second birthday. I have a wife. And actually the second go around, I actually got MRSA a second time about a year later. And my wife, I got dropped off at the hospital on Thursday night for an emergency surgery. My wife came in on Friday morning and gave birth to our third child, and she beat me out of the hospital. So yeah, I mean, look, and I became a serious germaphobe for a while, and so did my wife.
As far as you are telling your story, a dramatic one from the patient perspective, what advice would you have for other people who are told by their doctor for the first time you have MRSA? What would you advise them, since you've been through it now twice?
Well, I think the first thing is making sure that you're getting the proper medication. You know, the team orthopedic sent me home with I wanted to say it was Keflex, but I'm not 100% sure. Just a regular over-the-counter antibiotic, which wasn't going to do anything. I ended up having a PICC line in my arm for 6 weeks, getting pumped full of vancomycin the first time. And then I had an allergic reaction to that. So the second time they gave me a PICC line and a cocktail of antibiotics. And it is a scary moment, right? You know, it really is. The good thing is, again, this is 2004. There were drugs available that they hit me with, and they flushed me out, right? I had surgeries to take care of those things. But it is a very scary moment that you feel like you don't have any real control, right? We have this idea that, hey, I go to the doctor, I go to the hospital, they're going to have the answers, they're going to fix me, I'm going to be okay. And when you're told, hey, we're going to try these drugs and hopefully they work, that's an eye opener right there. So you know, I mean, look, I was fortunate. I had the best care in the world, right? The NFL, they take care of their guys, and I was in that situation. So I was very lucky. But I've coached high school football, Division II football. You know, I've coached ball, been around the game my whole life. Not every place has that level of care that I was fortunate to have in the NFL.
Why have you decided to speak out, and what do you think that, you know, we've been discussing today, government policies and legislation. What do you think that needs to be done to put more of the spotlight on this issue?
Well, I think number one, I came in, you know, obviously not through the whole talk here, but I caught the kind of tail end of the last few segments, and I think really one of the scary things to me is that this is the same conversation that was being had 20 years ago when I had this in Washington, right? Like, this is classic, gridlock. I don't know what you want to call it, right? You know, but like, is anything gotten done in the last 2 decades since I had it? And it sounds like we're still having the same conversation. That's a little scary, right? This is something that kills people, that is an incredibly painful process, no matter how you have it, right? If you have it in your skin or inside of you, this hurts. Like I said, I tore my ACL, my MCL, my PCL, dislocated my kneecap. The MRSA, way worse, way worse. So I think that the frustrating thing is I keep coming back and having these conversations and hearing the same conversations coming out of DC, coming out of the pharma world, and nothing's getting done, right? Look how fast we flipped this vaccine thing over for COVID. Like, just do it, man. It kills people. And I do think, to be honest with you, because of the fact that it affects everyone, as opposed to sometimes that group that can stand up there and say, hey, like, this is really affecting us. Sometimes in America, we don't really move too fast when it kind of goes after everyone. Obviously, COVID being, a different situation. But look, we can do miraculous things. Our pharma, our scientists, our people, right? They're capable of anything. Take the handcuffs off and let them go. Like, make it worth their while. Whatever you've got to do to help people. I mean, I heard somebody when I came into this thing, it kills more people than HIV, worldwide, right? That's terrifying. Like, why don't people know that? Why don't people talk about it? Why isn't it a bigger deal?
Brandon, we've run out of time, but thank you for sharing your story today. Really appreciate it.
Yeah, thanks, guys. Thanks for having me on.
My final guest today is going to be Dawn O'Connell, Assistant Secretary for Preparedness and Response at the Department of Health and Human Services. She is the agency's principal advisor on public health emergencies, and her office leads the nation in preventing and responding to and recovering from adverse health effects of man-made and naturally occurring disasters. Welcome, Dawn, to the program.
Bob, thanks so much. I'm so pleased to be here with you.
Well, Dawn, based upon your responsibilities at HHS, you've had a real interesting last couple of years. Can you tell us about specifically with antibiotics and what HHS is doing? I know there's a lot of public-private partnerships, but how does the HHS, which has been the forefront for COVID, deal with this issue?
Well, one of the things I've learned in the role that I'm currently in is I haven't had the luxury to focus only on the acute response that we're currently helping to coordinate and execute against, which is COVID. We also have teams that have not taken their eye off the ball for some of these other really concerning and worrying potential issues, some real, some around the corner. So we do have teams that have been focused on antimicrobial resistance through the course of even COVID, which has been a really good thing. And across the department, we've had a lot of efforts over the last decade in something. There was an initiative called Combating Antimicrobial Resistant Bacteria, and it was launched in 2014, and it's existed and sort of been honed in over the last 2 administrations since then, which is a whole of government effort focusing on slowing the emergence of resistant bacteria. That's something CDC is really involved in. Strengthening national One Health surveillance, that's seeing where the animal populations might be showing some resistance. That's a USDA function. Advancing the development of tests and diagnostics, the therapeutics and vaccines, all of those pieces, and then making sure there's a global health piece, since so much of this is going to be experienced worldwide. So just to say, all of HHS is engaged in this effort. The piece that I'm most responsible for in the role that I'm currently in is the development of future antibiotics that can be used and brought to market quickly. I have something in my office called the Biomedical Advanced Research Authority, or BARDA. And BARDA realized over a decade ago, about the same time that the CARB initiative was being launched across government, that when it comes to responding to public health emergencies, having antibiotics is critical, maybe sometimes as a first-line response, as we saw with Cipro in the anthrax attacks, and sometimes as a second-line response as a reaction to something that's occurred in a public health emergency. And the BARDA team was looking across the pipeline you've heard a lot about today, and seeing that it was drying up. And what BARDA's bread and butter is, what it does for the federal government, is it takes those things that companies don't find are marketable, don't find worth investing in, but are great ideas, and pulls them through the advanced research and development pipeline. So it often starts with biotechs who are very innovative, as you know, and are generating ideas, brings them through phase 1, phase 2, and into phase 3 and FDA approval processes. So BARDA pulls these critical components through that companies don't want to spend the money to invest in to get all the way to the finished product. So antibiotics, of course, is one of those things that BARDA's been focused on now for several years. Over the course of that, we've seen 3 to market, and we currently are invested in 18 additional products, and that's all through our advanced research and development. But over the course of this, what we realized was we were missing some of the innovation at the beginning, and we needed an accelerator. We needed an accelerator to come through and bring things along a little faster so we could start pulling them through phase 2 and phase 3. So in 2016, BARDA, along with NIH and the Wellcome Trust, launched something called the Carb-X accelerator, and that has since brought and focused on over 100 different antibiotic products to try to launch and bring in through this innovative phase that the BARDAs of the world and other advanced research and development entities could pull through to market. So we're very pleased with that effort and continue to stay focused on trying to look for more products that we can help and support. The other piece we found that needs a little bit of help, and I think this was referred to in a previous question, is what happens when you go to market and nobody wants to buy it, no one wants to invest in it. And so we've committed to something called 4 by 30, which is we would procure 4 new antibiotics by 2030 to be able to have on hand to respond to public health emergencies. And that would at least give 4 additional antibiotics the opportunity to get post-market procurement and post-market success.
We have a reader question for you. It comes from Christine Guaco-Pabia, Chief Medical Officer at Nebriva Therapeutics. And her question is, what steps are the relevant government agencies taking to support companies that are currently developing or waiting FDA approval of novel antibiotics?
So this is one of the places where BARDA plays, and this is, the piece that I'm responsible for, which is helping to make sure they can get through that phase 3, ramp up manufacturing, and then get the authorization and approval paperwork, data, all of that collected, packaged, and submitted to FDA. You also heard me say this is a cross-HHS effort. So while those are the pieces that BARDA does to help bring these companies through, NIH plays a role, of course, in early clinical work and support. And FDA is waiting on the other side of this to receive these data packets. So there is an awful lot of support and interest in HHS for this work.
Your office is responsible for maintaining the strategic national stockpile. What is the status of the stockpile today?
Well, the stockpile, it's certainly gotten a lot of attention over these last 2 years, as it should. Its bread and butter, of course, is maintaining and providing medical countermeasures for public health emergencies, and we're seeing some of the work it's able to do right now with the monkeypox outbreaks we're all reading about. And it does support and hold some antibiotics. We don't talk about those publicly for obvious national security reasons, but we certainly do have some on in stock and will continue to do so.
What about what has HHS learned regarding COVID-19? And as you know, in Washington, agencies go about their business, and appropriations kind of goes up a little bit each year, but obviously now we've had a pandemic, and health experts now, many of them are calling for, hey, we've got to invest way more up front so we can save on the back end.
Well, I think that's absolutely right. And we certainly saw some of the benefits of that, quick investment when we got those vaccines for COVID in under a year. That was remarkable, and it was a whole of government effort. Barda was pleased to be a significant part of that. And we've learned that lesson. We've done that now, and we know how to apply that moving forward. We're continuing to look at pandemic preparedness. There was a request in the president's FY23 budget for $88 billion to invest in future pandemic preparedness and to take those lessons, that manufacturing development, that quick process, and apply it to additional viral families. So we will continue to exercise that muscle and not lose the advantages and the strengths we've gained in this last very, very long and continuing response.
The response to in dealing with antibiotics, I mean, this whole issue, looking at the stats, and it's kind of grim. What advice do you have for people, whether they're patients or providers, in helping put the attention on this issue, which obviously has not gotten the attention it deserves?
Well, let me thank you all for doing this forum, because it does need attention, and it warrants attention. It's one of the most terrifying things we think about when you look across. If we lost antibiotics, if they all became resistant to one thing or another, we would lose the ability to do chemotherapy, the ability to do some of these complex surgeries. We've come so far in medicine, so it's really important that we continue to invest in the antibiotic pipeline. And one of the things that CDC has been doing is issuing guidances and recommendations for healthcare providers on when and how to prescribe antibiotics. When is it appropriate? When is it not appropriate? And I think patients play a role in that too. Is it an earache? And will an earache respond to antibiotics? Is it viral rather than bacterial? All of those questions need to be asked as we carefully look at preserving the current capacity we have. And then hopefully the work that Barda and others are doing will continue to bring more antibiotics onto the market, but that's a slow process. So we really do need to save and preserve the capacity we currently have.
Dawn O'Connell, thank you so much for joining us today.
My pleasure. Thanks so much for having me.
Well, that brings us to the end of our program. A big thank you to the Pew Charitable Trusts for their support, and to all of you attendees for joining us for this discussion. For those who may have missed any of the conversations, video from the event will be up on our website, thehill.com, shortly. I'm Bob Cusack. Be well.